Good afternoon and welcome to today's air-conditioned grand rounds. Please remember to sign the attendance record, and also please remember to fill out the program evaluation. And the CME committee would appreciate any ideas that you might have in regards to future topics, future speakers. Our topic today is the medical management of the pregnant patient, and our speaker is eminently qualified to discuss the topic. Our speaker is Dr. Brian Brost, and he is certified in both obstetrics and gynecology and maternal fetal medicine. Currently, he is Associate Professor of Obstetrics and Gynecology at the Mayo College of Medicine. He's the Acting Director of Maternal Fetal Medicine Division at Mayo Medical School, and he's the Interim Chair of the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology at Mayo Clinic, and he kindly drove down today to provide us with some education. So please join me in welcoming Dr. Brost.
Thank you for having me today. Can everybody hear okay? This is the first time I've used one of these mics, so we'll see if it works okay. If you can't hear something, let me know. If you have a question, please let me know. I'd like to make this as interactive as we can, but it's a little hard from the distance here. It's kind of like being in church. Everybody sits in back. Medical management of the pregnant patient. To me, it's a fascinating topic. Most people go, really? Is there a pregnant lady in my clinic? Why aren't they in obstetrics? Why aren't they seeing the midwives or family medicine? Why are they in my clinic? So I have to do a disclosure slide. I don't have anything related to the talk today. Again, if there's any issues, please let me know. I've tried to keep everything as generic as I can. What I thought about the medical management, there's two main areas. Diabetes and chronic hypertension are some of the biggest areas, problem areas during pregnancy. I'd like to talk a little bit about thyroid disease in pregnancy and also a little bit about asthma. And I think that will cover the 45 minutes that we have today. Mainly talking about how do you do this if you're an obstetric provider or if you're a non-obstetric provider having to see that pregnant patient in the clinic. Now, one of the things that bother people the most is a patient calls you and says, I've got a positive pregnancy test and I'm taking this medication. What should I do? What's the answer? Everybody says, stop it, right? Because it might cause problems for your baby. So I'd like to spend a little bit of time, at least on the front end of this, talking about medications and what we do and don't know about these medications. The FDA gave us all these categories. Like we're going to sit there and read all this, right? Unfortunately, they named it A, B, C, D, and X. The A, B, C, D sounds like letter grades in school, doesn't it? Like A is really good and C is, okay. Obviously, X makes sense, don't use it. But that's not really what this guide tells us. If we look at A studies, there's controlled studies in women that fail to demonstrate a risk to the baby. How many women will say, yes, I'll take that medication and see what happens to my baby? Okay, so there's not going to be many A's. Everybody wants an A medication, but they're not going to get it. Most of the medications start off as C, meaning that there's studies in animals that have revealed adverse effects, and there are no controlled studies in women, or their studies in women and animals are not available. So most medications are a C. If you're looking for something else, you're not really going to find it in most cases. So let's look at this. Patients, providers intuit that a category A drug is superior and safe. What drug company is going to say this medication is safe in pregnancy? They're not. Who makes these guidelines? The medication companies. So if you're looking for that, you're not going to find it. The problem is birth defects happen. If you have no family history or no medications, you're on no medications early in pregnancy, birth defects happen. We can't change that. There is a baseline rate that we can't get better than. Because there's that baseline rate, what we're really looking for is there an increase in all birth defects or in specific birth defects, say the heart or the kidneys. And the way we find that is women who didn't know they were pregnant, were on the medications early in pregnancy, and we're continuing the pregnancy so we could see the outcomes of the data. Not very strong type studies, but that's what's available to us. So you want those category A medications? Here they are. I went through the whole book. So you can see that there are some vitamin type things, there's thyroid medication, and water. Okay? So if your patient wants an A medication, you can tell them that you've seen the entire list, and what they have is not on the list. In the ideal world, we would be prepared. We would know before a pregnancy happened. So we could adjust the medication either to a lower dose, trying to keep it safer for the baby. There's a dose effect. The higher the dose, the worse the problem. Or we can take them off of it, make sure they're stable, and then say, okay, go get pregnant now. How many pregnancies are unplanned? More than half of them. So that being the case, it's up to the provider who's seeing them for well visits when they're not pregnant to say, are you using good contraception? If you're not, are you prepared for pregnancy? So these are things that we can talk to them about. So let's talk a little bit about pregestational diabetes. Pregestational diabetics, there's probably about 8 million women in the United States with this. Given the frequency of pregnancy, that counts to about 1 to 2% of pregnancy. Most of the diabetes we see in pregnancy is gestational diabetes, GDM, counts for about 90%. Most of those are diet controlled, so we don't even need to put them on any of those medications. So the key point is with pregestational diabetics is that down the road, they are likely to develop diabetes. So if you have a woman in your clinic who had gestational diabetes, you need to screen for that. The original test by O'Sullivan was to not do anything for the mom or the baby during pregnancy, but as a screening test down the road who was going to develop diabetes. It was a stress test for future diabetes risk. Type 1 diabetes, autoimmune destruction of the beta cells of the pancreas. Type 2, which is becoming increasingly common in the United States because of increasing obesity, is a function of insulin resistance. So if we look at the frequency of this, it's gone from about 5% in 95 up to about 20% in 2005. Much higher rates. The risk of this pregestational diabetes is related to glucose control during pregnancy. Too high of a sugar level is teratogenic to the baby. So all these moms that are worried about the medications they are on should be worrying about things we can control, your sugars. If you're not on contraception, you need to be thinking about when I get pregnant, what's going to happen to my baby. Later on in pregnancy, high levels uncontrolled increases the risk of macrosomia and therefore cesarean delivery and also stillbirth. If we look at the rates of these during pregnancy, in type 1 diabetics, not gestational diabetics, but type 1 diabetics, the rate of birth defects is about 6 to 7%, 1 out of 20 or higher. That's pretty significant. And it's solely related to glucose control. The normal rate we talked about being 2 to 3% that we can't change or alter. The rate of cesarean delivery is almost 50%, very high. Large babies, 30%. Preeclampsia, 10%. And you can see compared to normal, there's a vast difference. Even stillbirth and RDS are related to glucose control during and at the time of delivery. So the goal in any clinic, pregnant, non-pregnant, is excellent glucose control. Pregnancy is one of those ideal times to get somebody in an ideal state of control. When I was doing my fellowship, I had a young lady, the baby had a neural tube defect. That's why she was coming to see us. And she looked at me, she was 16 years old, married to a 16-year-old, dating. And she said, did I cause this for my baby? Did I cause this neural tube defect to my baby? And I had to say yes. It's a possibility because your hemoglobin A1C is 12.8, which means poor glucose control in the early time of pregnancy. Right about the time you had your period, or should have had your period, that's when the neural tube is developing. We don't have time to adjust or change. So she said, I'm not going to hurt my baby anymore. She got under excellent control. She felt so good for the first time in her life that she made him get under excellent control, and they had 2 more pregnancies with normal babies. So pregnancy is a time to do that. The fear of pregnancy also might be a time to say, let's think about this. The caloric requirements increase about 300 kcals, and I've got some formulas here. There's some handouts. I'm not going to go over all the numbers. I put a lot more information on the slides than I usually do, so you don't have to sit there and write it down. So some of the stuff I'm going to go over fairly quickly because it's in there. If we think about the caloric composition, ideally 40 to 50% complex high-fiber carbohydrates, 20% proteins, 30-40% fats, primarily unsaturated if you can get them. Now, how many people know what foods fall in those categories? I thought back to medical school, how many classes I had on nutrition. It was 0. That's why we have registered dietitians. They're wonderful people. They can provide that specialized care, that personal touch that we need for pregestational diabetics. Okay? So the calories, these are just ballpark figures. When the woman goes to the dietitian, she's going to say, what's the big meal of the day for you? Is it dinner or is it lunch? And then help proportion that out for them. The most important thing is remembering snacks. Because the glucose, the things we use to control glucose in pregnancy affect everything, we have to make sure that there's food in their stomach kind of on an ongoing basis because insulin is acting on an ongoing basis. Pregestational diabetics are typically used to checking their blood sugars before meals. And then they figure out how many doses, units of insulin they're going to give themselves. In pregnancy, we do it slightly different. If I have a non-pregnant mom and she eats a meal, her glucose will go up, and then it will come down in a relatively predictable pattern. Somebody with insulin resistance or diabetes, the sugar will go up and stay up. So the goal, the reason we check after meals is we want to know that it's coming down and when it's coming down. Now, things like checking 2 hours after meals is what we used to say all the time. That's really inconvenient lifestyle. You've got to do your insulin a half hour before your meal. You've got to eat. Then you've got to check 2 hours after the meal. It doesn't work really well in life. So people have switched from 2 hours to 1 hour, and ideally we want the sugars less than 140. Some folks still check preprandials, again, making sure that the values are between 60 and 95. Nighttime, we don't want it to go below 60. Now, how do you know that? Pregnant ladies, know it or not, get up all night long, go pee. So if they feel funny, they need to check their sugar, okay? If you have really high sugars in the morning and you've increased the dose and the sugars are going higher, then we need to start thinking about Somogy effect. That during the middle of the night, they're bottoming out their sugars and then releasing stores internally to help make up for that. So checking 6 to 8 hours after their last meal or their last insulin dose, typically we use NPH, 6 to 8 hours after is a good time to check that. The target goal overall is a hemoglobin A1C of less than 6. If you have somebody in your clinic and they said, I'm thinking about getting pregnant, check this if they're a pregestational diabetic, and if their glucoses are 8.5 or higher, you can say that their birth defect rate is in the order of 20 to 25%. That's significant. That will catch their attention. Check for urine ketones if glucose is greater than 200. Now, this is a different number than our internal medicine colleagues use, because usually they don't see diabetic ketoacidosis until the 300, 400 range. In pregnancy, it's lower. Because of the insulin resistance that's happening, the value is lower. If we look at the different medications, there are some new ones right now, Lispro and Aspart, that have almost immediate onset. This has really helped with glucose control because you take your insulin right before you eat. If you take it a half hour ahead of time, somebody's going to distract you, something's going to happen, and every once in a while you'll miss that meal or it'll be late and you'll go low. So this is really nice compared to the regular that we traditionally use. The peak for regular is 2 to 4 hours after that. So think about what we're trying to do. We got that insulin load going up and we're trying to get it to come down in a pattern like a non-diabetic pregnant woman. There is some new medications out. Glargine is one of them, and Dedimer, I think, is the other, that are synthetic made insulins, artificially made insulins, that have no peak. So some of those benefits of the insulin pump, of that constant infusion, we might be able to do with a shot in the not too distant future. The trouble is there's not a lot of information on that in pregnancy. We don't have information on that. One of the things that we look for is what happens to that dose of insulin. As the pregnancy goes along, the placenta makes human placental lactogen, a hormone that counteracts insulin, makes sugar hang around longer. That's great for a developing baby. When they're this big, they don't need much sugar. As they get bigger, they need more and more. The placenta gets bigger and helps make more, but sometimes it kicks in too soon or too fast, and that's that gestational diabetes or problems with insulin control where we have to increase her dose of a pregestational diabetic through pregnancy. If this all of a sudden starts going down, don't assume that that's a wonderful thing. If it's going down, then something's happening to that human placental lactogen. Maybe the placenta's not working well. That's a time where we have to start monitoring the baby closer. That's when stillbirths can happen. Okay? So that's kind of one of those points to think for. The recommended workup early in pregnancy, one of the most important things we can do is date the pregnancy. When a baby's this big, doesn't look like mom or dad yet, doesn't even look like a baby yet, looks like a little bean or a rice grain or something, it's very exact. As the baby gets bigger, and then we start adding in maternal conditions and genetic factors, there's more variation. So we want to know how far along that baby is early on. So we want an early ultrasound. We do the routine obstetric labs, especially urine culture. UTIs will throw off sugar control. So we want to make sure that a pregnant lady doesn't have asymptomatic bacteriuria. Pregnant ladies pee all the time. They don't feel dysuria, so those classic signs or symptoms of UTI don't show up. Check a hemoglobin A1C, check a baseline renal function. We'll talk about why in a second. Gestational diabetes appears to be an autoimmune type process, so does thyroid disease, so we need to check because often they will coexist, or particularly during the postpartum period, they will often need, up to 20-30% will need thyroid replacement. Electrocardiogram and then a dilated comprehensive eye exam by an ophthalmologist. From the obstetric side, that early dating ultrasound, anatomic survey, 18 to 20 weeks. We're looking for evidence of a birth defect. Is there a problem going on with the baby? We focus particularly on the neural tube, the spine, the head, anencephaly, cardiac, and kidney. Those tend to be the main areas, but all defects are increased. We start watching ultrasounds for growth. If the baby's at the 95th, 97th percentile, mom's going to get a little worried about it's going to go out where? Twice weekly testing starting at 32, 34 weeks. Sooner if you have somebody that's poorly controlled or there's evidence of abnormalities on the ultrasound. Delivery will vary depending upon the type of pregestational diabetes she had. Bottom line, poorly controlled pregestational diabetics leads to serious end organ damage. This is not isolated to pregnancy, this is through life. If we can make it better, if they can feel better, we can make a big difference for the rest of their life. Serious end organ damage prior to pregnancy makes it harder to get pregnant and makes the outcomes worse. So Priscilla White had this classification system. We all had to memorize this in school, right? It's easy to forget. A is gestational. If it's diet controlled, A1. Insulin or oral therapy, A2. Type B is milder. It started later in life, greater than 20 years, or shorter duration. C, 10 to 19 years onset and duration, and then D includes early onset as a child, less than 10 years of age, or greater than 20 years of duration. Benign retinopathy will also bump it into that category. That's why that eye exam is important. As we start at the top of the list, A, B, C, that's where you get those humongo babies, the sumo wrestlers. You know, they come out and they look like they're ready to go to kindergarten. As we start going D, R, F, H, T, that's where we end up with smaller babies. The top ones often have poorer control and more likely to have pulmonary issues for the baby, respiratory distress. As we go down, prematurity, low birth weight, stillbirth, more likely to happen. That's how that category is helpful. Retinopathy, we break it down into background and proliferative. Proliferative is important because if you have neovascularization, we can laser that, we can help protect her eyesight. So you want to check that early in the pregnancy and if they're having lasers frequently during the pregnancy. It's not just go get an eye exam with the local, optometrist. You need somebody to look in the background of their retinas. Poorly controlled diabetics with hypertensive disorders, if you aggressively normalize those sugars, you're pregnant, we got to get it under control. If they have a hypertensive disorder, they're more likely to have rapid progression of eye disease. So you have to be thinking we're going to send you more frequent early on while we get this control on the early part. Nephropathy, if there's pre-existing nephropathy, it's associated with poor outcomes. 5 to 10% of pre-gestational diabetics will develop proteinuria during pregnancy. Usually it's reversible. Occasionally it stays on. Baseline renal assessment is important. All pregnant ladies love to do a 24-hour urine. Just ask them. They love to do that and check for total protein. So that's something that we can do and should do early on. And then we can say, is there progression of the proteinuria during the pregnancy? If they have chronic hypertension, it will, or diabetic women will also develop hypertension during pregnancy. They have increased risk of preeclampsia, IUGR, and stillbirth. Often these ladies will be on ACE inhibitors. And they'll read the book and say, well, that causes renal problems for the baby. Stop it immediately. It's not stop it immediately because those problems don't happen until the early second trimester. So don't panic. You have time to transition them to another medication, and we'll talk about those in the next set. Ideally, you stop it before pregnancy, but if she shows up, 50% unplanned, if she shows up and says, what do I do now? Say, we need to transition you to another antihypertensive. DKA occurs in about 5 to 10. That number shows up a lot in pregnancy, doesn't it? 5 to 10% of pregestational diabetic women, usually they have type 1. It occurs at lower glucose levels. If you have somebody that has a sugar greater than 200, they need to be checking ketones. We don't want them in that range, but if it happens, we need to check. Common reasons are infections, sepsis like influenza, UTI. So we have to check for reasons like that. Poor compliance. How many people have the ideal compliant diabetic patient? I think there's one in each community. There's something about diabetes and compliance that just often doesn't go well together. Pump failure. We're having more and more ladies on pumps. That might be the first sign of a pump failure. The site's not working, the pump's not working. Treatment for preterm labor, preterm delivery. We use beta mimetics sometimes to stop it. We use corticosteroids to help the baby do better after birth if they're premature. Both of those will drive her sugars wild. She needs to be admitted and watched. The typical presentation includes abdominal pain, nausea, emesis, and altered sensorium. Sounds like pregnancy, right? So it's really hard to figure out some of this stuff during pregnancy. And none of you better tell my wife about altered sensorium. Fetal mortality has decreased, but is still about 10%. Management, I wrote this down just for information in case you're going to seldom see it, but at least it's all down in one place if you'd like to look. Preconception counseling is important. Every diabetic woman you see, you need to talk about these issues. It'll take about 5-10 minutes, but it will make a big difference in her life and the baby's life. If we can prevent birth defects, that's important. If you've got a lady who's got a hemoglobin A1C of 8.5 or higher, you have to say, if you got pregnant, you've got a 20-25% chance of a birth defect in the baby. 1 out of 4, 1 out of 5. If we had those odds in the lottery, it'd be great. But in the genetic lottery, it's not that good. If we get the hemoglobin A1C in the 5 to 6 range, then the birth defect rate goes back to that baseline rate, 2 to 3%. If we can keep the women there, they'll feel better, they'll do better, and pregnancy will be less of an outcome. We're going to switch gears to chronic hypertension. Occurs in about 5% of pregnancies. Hypertensive disorders fall into 4 categories in pregnancy. Chronic hypertension is pre-existing diabetes, high blood pressure, or onset before 20 weeks gestation without proteinuria. Gestational hypertension happens after 20 weeks gestation, but no proteinuria. Preeclampsia, eclampsia, HELP syndrome occur only during pregnancy, which makes it really hard to study. It occurs only in a pregnant woman. We can induce it in some animal models, but otherwise there's no ways of really testing it. Animals don't get preeclampsia. Only humans get preeclampsia. Makes it really hard to study. If they have chronic hypertension, they can get preeclampsia superimposed on that. So it gets really hard to figure out which is which. So if we're thinking about what's going on, we have to know what happens to blood pressure during pregnancy. So if you have a pregnant woman and this is her blood pressure, I'm just going to wave my hand there, okay? So that's her blood pressure, kind of steady. The first trimester, it's going to stay the same. So if you see somebody in the first 12 weeks of pregnancy and their blood pressure is high, they have chronic hypertension. Then in the second trimester, there's a nadir. Their blood pressure drops, and it peaks, it naders at about 16, 18 weeks of pregnancy. So if her blood pressure is 125 over 85 at 18 weeks, I'm really starting to think this lady's got high blood pressure. If that was her first visit, if that's the only blood pressure I have, I'm going to be watching her close through the rest of the pregnancy. The later second, third trimester, it should go back to that baseline value. So we have to think of what happens in that middle part, and it will help us. There are some medications we use. Methodopa has been around forever and ever and ever and ever. So we've got tons of experience with it. If you talk to an internist, some of them have not heard of methodopa or they forgot about it because nobody uses it. It is a crummy antihypertensive. It takes a long time to work, and it doesn't work really well. Well, that's kind of what we want in pregnancy in some ways, isn't it? We don't want to drop the blood pressure all of a sudden, so in some patients it might be right. Many women do not obtain control with this medication alone. We have stopped using it as a first-line agent, even though a lot of the books still will sometimes say that. It just works so poorly and takes so long to work, and the adjustments are horrible. And we've had several ladies have liver function test abnormalities. AST, ALT will start rising. So we've stopped using it. Beta blockers, there's a question of association with some organ-specific birth defects. Cardiovascular, the heart, cleft, and the neural tube. Kind of sounds like diabetes, doesn't it? Similar to what we see in diabetic women with poor control. Labetalol is the most common one we use. It has alpha and beta adrenergic blocking activity. That helps preserve blood flow compared to some of the other agents. And so this has kind of been one of the standbys we use. We use labetalol and we use a calcium channel blocker as our main ones right now. Onset within 2 hours of taking it. If you look at atenolol, often we'll use that for heart block or other things. Atenolol, lower placental and fetal birth weight. Now think about what we're treating. We're treating hypertensive disorders. Hypertensive patients, even if they're not on medications, have lower placental weight and lower fetal weight. So it really is hard to say, is it the disease or is it the medication that is causing this? So your patients will look at it. All of the beta blockers have this listed as intrauterine growth restriction as one of the problems with it. And we have to explain that high blood pressure might be worse for you and the baby than the risk of this. And even if we don't put you on the medication, you're still at risk for the same thing. So we have to talk to them about what we know about the medication. Calcium channel blockers, generally reported as safe. Haven't seen a lot of birth defect issues with it. There are some people who will get headaches when they first start taking the calcium channel blockers, nifedipine being one of the more common ones we use. Limit the immediate release. A lot of people will take it sublingual or park it on the buccal to get a rapid drop in blood pressure. Not good in pregnancy. Babies used to seeing a fairly high blood pressure to perfuse that uterus placenta. There might be some damage to the placenta, and if we drop the blood pressure acutely all of a sudden, the babies won't do well. They'll have some bradycardia associated with it. Hydralazine is kind of one of the more common ones we use IV, typically used for acute hypertensive crisis, can be used orally but has issues or problems orally. So again, labetalol, a calcium channel blocker, and a beta blocker is where we tend to go. Thiazide diuretics. People always panic about that. I'm on a diuretic and I'm pregnant. The most profound impact intravascularly is in the first 2 weeks you take it. Otherwise, your body adjusts to it. So if you're on it and it's controlling your blood pressure well, I continue on it rather than try to find something else that works. If I need to control somebody during pregnancy, this is not one I use because of those changes intravascular and the possible effects for the baby. ACE inhibitors, ARBs, direct renin inhibitors, those are all ones that we shouldn't use during pregnancy. Those are the ones we use in the pre-gestational diabetics because with renal problems, because it works well for them, help preserve renal function. This is the one people panic about. Tell them not to panic. You're only 6 weeks. You're only 8 weeks. We don't see those birth effects at this time. We just need to transition you to a different medication. Come see me, we'll get it all set. Some people say for chronic hypertension, put people at bed rest. If you put a pregnant lady at bed rest, she's at increased risk for clots, which will kill her, as opposed to high blood pressure, which we can control. Diet, a lot of people in the past said salt-restricted diet. That can cause low intravenous volumes, so normal diet. Don't add extra salt, but don't restrict salt. Indications. If somebody has mild hypertension, systolic 140s up to about 160, diastolic 90 to 110, if they're in that mild hypertensive range, it's not been shown to make a difference for mom or the baby by using antihypertensive therapy. When it gets higher, then it's necessary to use it, but there's no benefit except maybe a slight decreased risk of severe hypertension, but that's going to happen whether we put her on medications or not, if it's going to happen. Insufficient risk to warrant exposing the baby to adverse effects in mild hypertension in pregnancy, mild range hypertension. So you have that hypertensive emergency, and you have to figure out who has a higher blood pressure, you or the mom. When she comes to your labor and delivery or your ER and their blood pressure is 200 over 130, and you're going, oh my gosh, she's going to stroke, she's going to have an ischemic event, something's going to happen along the way. Labetalol has become the first line agent. The dose is 20 milligrams IV. You give it slow push over 1 to 2 minutes. If it's not working within 10 minutes, you can give either the same dose or bump it to 40, depends upon whose blood pressure is higher, yours or the patient's, and then give at 10-minute intervals until you get a response, increasing doses of labetalol. Max dose, it should say 2,400, not 24,000. Cross out a zero. Cross out a zero on your forms. I'm sorry about that. It should say 2,400. Decrease within, you'll notice a decrease within 5 to 10 minutes if you're going to get a response. So once we get to 10 minutes, we haven't seen a response, then it's time to go. Last for 3 to 6 hours. This is important. You can't give her a dose and say, oh, your blood pressure's fine, see you tomorrow morning. You got to get her on some other oral agent to keep it low over time. Hydralazine has been a standby. Initial dose is 5 milligrams, repeat doses in 20-minute intervals, 5 to 10 milligrams until a response. Sometimes you can see some changes or acute drops with hydralazine. And again, babies don't tolerate this well. Target, systolic blood pressure, 130 to 155. We're not trying to make it normal. Babies used to seeing higher blood pressure. We need to keep it in a safe, high blood pressure range for mom and a safe range for the baby. So we're not trying to normalize it. Diastolic blood pressure, 80 to 100 milligrams. Goal is to reduce the mean arterial pressure no more than 25% over 2 hours. The problems with adverse events, we see normal pregnant women, women with mild hypertension, women with severe hypertension, superimposed preeclampsia, you can see a steady progressive rise through those ranges. Abruptia placenta. The placenta comes off the uterus. Not good for the baby dies. Less than 1% up to 5 to 10% with the high blood pressure, severe blood pressure range. That's why we need to bring it down to help mom and the baby. Severe range blood pressures cause poor growth, and often we deliver the babies early. Often we end up delivering these babies early, at least 2/3 of the time. If you have a new mom with hypertension, the evaluation, you can evaluate for secondary causes if they don't respond well to the medication, if they're resistant, or if they have a family history. It's uncommon in the non-obese woman under 30 with no confirmed family history of hypertension to find secondary hypertension. So those are the ones that you start looking at if you don't see that. Baseline laboratories, very similar to what we had for a diabetic. Again, checking TSH and free T4 and electrocardiogram for long-standing history. Fetal evaluation. We talked about big babies and the A through C diabetics. In the chronic hypertensives, especially those with poor control, we see small babies. And we need to know early on, is this baby growing normally on its growth curve, or is it slowing its growth? Early dating ultrasound is important. Anatomic survey at 18 to 20 weeks. Checking for growth, 28 weeks, growth in fluid. Checking mom, can check every day. Mom can do her own testing at home and make sure the baby's moving well during that period of time. Once or twice weekly testing, depending upon is it controlled or is it high. Delivery, wrote the different times there based on how she's doing, how mom's doing. Thyroid disease, interesting thing. How many of you have had TSH or T4 test in a pregnant lady? What happens to them? Very often it looks like subclinical hypothyroidism, right? Or hyperthyroidism. Estrogen causes an increase in the thyroid binding globulin, increases twice its time. The total T4, T3 increase. The free T4, T3 increase slightly but stay in the normal range. These are normal during pregnancy. In 10 to 20% of pregnant women, TSH is transiently low or undetectable. Some people say, look, universal screening, all pregnant women. We did that, and we got this, and we freaked out a whole lot of women because they read about hypothyroidism and what it means for the baby, hyperthyroidism, what it means for the baby. If a woman has a beta HCG greater than 400,000, you will see this. You will see this because of that homology. HCG has a common alpha subunit with TSH, so the test confuses them. Trimester-specific TSH ranges, you see these don't look normal for non-pregnant women, right? These are not normal, but these are normal during pregnancy. So if you were to check, or somebody sends you and said, we checked a TSH and it looks low, and you have a normal free T4, you can wait it out in the first trimester. As we start getting further and further along, it gets hard to ignore that. Hyperthyroidism, overt hyperthyroidism, is rare in pregnancy. Most women know they have it. Most women go to the doctor, get treated for it. So we are dealing more with hypothyroidism in people who have had surgery or radioiodine ablation or things like that. The complications are miscarriage, preterm labor, low birth weight, stillbirth, preeclampsia, and heart failure. So if you have a woman with precurrent miscarriage, hyper and hypothyroidism can cause it. So it's an easy test you can do to evaluate for recurrent pregnancy loss. If the diagnosis happens if the TSH is less than 0.1 or it's undetectable, then check a free T4. If the free T4 is normal, check a free T3. Okay? So it's kind of a cascade of events. The goal of treatment is to maintain the free T4 in the high normal range. We want it the high normal range because we don't want that treatment, which can cross to the baby, to cause problems for the baby. The treatments we use, I learned that PTU is the treatment of choice because methimazole causes cutis aplasia, a birth defect that seems to only or mainly happen on women being treated with methimazole. Now they're finding that the PTU causes liver failure that's non-reversible occasionally. That's a big, big problem. So we're trading liver failure with cutis aplasia on the baby, and cutis aplasia is the one that had to give. We got to treat it, we got to do something, so methimazole is the drug of choice right now. Fetal and neonatal graves. Whatever's causing this to the mom, those antibodies can cross to the baby. So we can sometimes see placental transfer of TSH receptor stimulating antibodies, and we know the baby has it by high heart rate, 170, 180, 200. Fetal goiter, we can actually see that on ultrasound and measure it. We know what normal values are. Poor growth, craniosynostosis, the bone joints, the fontanelles, everything fuses prematurely. That's a problem for the baby. And then cardiac failure, hydrops, one of the causes of that in pregnancy. The treatment is treat the mom. If we see those symptoms in a lady who has hypothyroidism, who's on thyroxine treatment, we give her PTU or methimazole to cross to the baby to treat the baby before birth. That's a way we can do that. Other alternatives, we use beta blockers for rate control in the mom. If she has high rate, pulsatile rate problems with that. Otherwise, if she's asymptomatic but has a fast rate, I don't treat them. She's symptomatic, often they'll feel better on a short course of beta blockers. As you correct the hyperthyroidism, you can pull the beta blocker off. Surgery. We can take the thyroid gland out. Then we're not going to have any more trouble with hyperthyroidism, right? And we've got to give her replacement. Radioiodine. Once or twice a year, I get a call from a mom panicked because she had radioiodine therapy right before she got pregnant or during the early pregnancy. The fetal thyroid is not there until 10 to 12 weeks. So it doesn't matter if she had that therapy early in pregnancy or immediately before pregnancy. It's an issue if it's later in pregnancy. And then we can actually destroy the fetal thyroid if they get this. like it does for the mom, it can do the same thing to the baby. Hypothyroidism, underdiagnosed or unsuspected, is rare in the United States. Complications, fertility, miscarriage, preeclampsia, all those things start sounding a little familiar, right? Neurocognitive impairment, that's for the mom or the baby. Mom or the baby. And so it's important to correct or make sure that women who are supposed to get thyroxine treatment are actually taking it. Diagnosed as subclinical in 2 to 3% of women. Treatment gives good maternal and fetal outcomes. Women with pre-existing hypothyroidism may need a dose increase during pregnancy. So we check every trimester a TSH and make sure she's getting adequately replaced. There are different formulations of thyroxine. So you have to make sure, if you're switching from one to another, to check and make sure her TSH is still okay. It takes about 4 to 6 weeks to see those changes, but if she had a different pharmacy and they had different preparations, you've got to check it and make sure. These are some doses you can use if you have somebody new onset. Asthma occurs in about 4 to 8% of pregnancy and is potentially serious. If mom can't get oxygen to herself, she can't get it to the baby. It's going to be a problem. The National Asthma Education and Prevention Program said it's safer for pregnant women to be treated with medication than to have the attacks, the asthma attacks. These are things you can talk to your patients about. These are safer for you to do and to use. Optimal therapy, we use objective monitoring of lung function, avoid triggers, talk about education for the patient, and most importantly, individualize the pharmacological therapy. There are some things that we can look at. How often does she have symptoms? Is it intermittent? Is it mild but persistent? Is it moderate persistent or severe persistent? Based on symptoms, is it less than 2 days? Nights? Does it happen 2 times a month? Does it alter her activity level? And then what's her peak flow? So we can categorize using some very simple things. There's a step-by-step therapy management. If it's mild intermittent, you don't need to do anything. You might have an inhaler available for PRN use. If it's mild persistent, use a low-dose inhaled corticosteroid. Alternatively, you can use theophylline, but you've got to measure levels. Women worry about corticosteroids because they'll read that it can cause a cleft lip in the baby. Cleft lip, cleft palate. This is inhaled. It stays local. It's not systemic. It doesn't cause it. You can reassure them that the inhaled steroids are fine. Moderate, preferred low-dose inhaled with some Meterol, or a medium-dose inhaled corticosteroid. Severe, high-dose inhaled corticosteroid, or you can go to theophylline. The levels are all the same for that. Field surveillance is the same. Early dating, daily maternal assessment, some growth ultrasounds, watching for problems, and there you have it. Medical complications in pregnancy. Pregnancy made easy, hopefully. Any questions? I'd be glad to answer. Oh, everybody's scared of pregnant ladies.
I am scared of pregnant ladies, but only if I am married to one. That was a great talk. Thank you for that. I wanted to ask about Singular. I believe that's a Class B in the Committee of OB Docs and Allergists. I think they're good with that. Thoughts on
again,
that?
a lot of the inhaled things are going to stay local in the lungs. You would think there would be great absorption, that there would be a lot of systemic effect, but there's not. That's the advantage of the inhaled or the Singular type therapies.
Well, you mentioned diabetic retinopathy, proliferative diabetic retinopathy. These days, anti-VEGF treatment is kind of common, but there is also the issue of the effect on the baby. Any comments?
Yeah, there's not a good comment to make about that. I mean, if they need that, then we have to do it. I mean, again, we focus a lot on medications and birth effects. You know, what are the effects on the developing baby? We have to think about what time in pregnancy are we? If we're in the 2nd or 3rd trimester, will a birth effect happen? No. Organogenesis is the first 8 weeks, 6-8 weeks of pregnancy after conception, so up to about 10 weeks or so. So if we have a woman who's on medication after that, stopping it's not going to make a difference. If there's a birth effect related to that, it's already happened. If we need to use certain medications after that, we're not going to cause birth effects. So then we start worrying about, does it affect fetal growth? Does it affect the baby's ability, the baby's immune system at birth? Or breastfeeding? Does it affect breastfeeding? Does it get into the breast milk? What are the effects on that? The American Pediatric Society just came out with a new statement about breastfeeding with medication use. I have to admit, it just came out. I printed it off. I didn't read it, but no, it's out there. It was just published, and it was about 10, 12 pages long. And I think what they say is that in most cases, the amount of medication that gets in the breast milk is small enough that it won't affect babies. That's been their general statement. I'll be interested to see what this shows. Wonderful. You guys have a great OB day.